Caucus to address some of the issues that I'm sure the chairman talked about, the issues of suicides, the issue of these kids coming back, a lot of them falling through the cracks. How do we prevent it? And I've been working on a program that's called, goes through the Mind Training Institute, which begins a mindfulness-based training early on, and they've done a couple of studies that are beginning to show that this mindfulness practice can help these soldiers and Marines build up a level of resiliency in their brains that can begin to inoculate them. Some people call it mental armor, to help them build up the resiliency so that when they go off to war, they are more equipped and better equipped to deal with a lot of the issues that they are dealing with. And the Mind Training Institute is one. In fact, last week we had the Joint Chiefs of Staff in front of the Defense Appropriations Committee. I mentioned it, but then after went to General Amos and talked to him about the program. The Marines are super psyched about this. I know it's going on in all levels of the military, but here I am talking to General Amos about a mind fitness training, and he said that, you know, the Marines are very, very excited about this, are very much looking forward to ramping this up throughout the entire Marine Corps, which I thought was super cool and very needed. And I just want to tell you one quick story. I was out in LA a couple weeks ago, and LA VA got a innovation grant, and they're starting to do a lot of different alternative therapies with veterans. Mindfulness-based techniques, mindful movements, guided imagery, all kinds of different alternative therapies. And we sat after one of these sessions with a group of veterans, some of them, I'd say most of them from Vietnam. And to sit there and have a conversation after one of these sessions, after it was basically a 30-minute guided imagery, guided meditation session, but to sit there and have Vietnam veterans say to me, this has saved my life. Or I don't think about killing myself every day anymore since I've been doing this program. And there's no side effects, there's no drugs. Some of them are obviously on some medication, but I think these alternative therapies, from my vantage point, after looking at this for a lot of years, is the way to go. And we've got to explore this because it's helping people, it's saving their lives. I can't tell you how, because I'm into this probably more so than most, how many vets I have met that have gone through this, and it's saving their lives. And it's one of the Vietnam vets said, I can't believe I've been carrying this with me for 40 years. And said, we need to get out to these young vets and communicate to them that you don't have to live your whole life this way, that there are things out there that can help your mind, your body, your emotions, your nervous system, the way your brain functions. There are things out there that can be very, very helpful. And they want to now go out and continue to try to promote it. And then just lastly, I don't know if anyone saw this, there was a great documentary this past week on CNN called Escape Fire, and it was about integrative medicine. But there was a huge piece in the documentary about the military and about some of the soldiers coming back, and they followed one soldier through and how much some of these treatments helped. So thank you for being here. Thank you to the panel. Let me introduce everyone very quickly. Captain Julie Miller in the middle, clinical psychologist in the Navy's Behavioral Health Program, subject matter expert at personal readiness and community support. Colonel Lillian Dixon, Deputy Director, Human Resources Policy Directorate for the Army. That sounds important, Policy Directorate. Ms. Sherry D. Simmons-Coleman, Acting Chief, Army Suicide Prevention Program, Human Resources Policy Directorate, Army, and a retired Sergeant Major, E9 in the Army. Major Kathleen Crimmins, Clinical Psychologist and the Air Force Suicide Prevention Program Manager, Air Force Medical Support Agency. And Dr. Adam Walsh. Yes. Nothing gets by me. licensed clinical social worker and a suicide prevention analyst and subject matter expert for the United States Marine Corps. So thank you so much for being here. Thank you for being here, and off we go.
Mr. Chairman and members of the committee, thank you for the opportunity to discuss information today regarding the accomplishments of the Department of the Navy's Suicide Prevention Program. From my perspective. Thank you for the opportunity to discuss information regarding the accomplishments of the Department of the Navy's Suicide Prevention Program from my perspective as a SME or subject matter expert for OPNAV N-135's Behavioral Health Policy and Programs Directorate. This directorate includes Navy suicide prevention and operational stress control. The loss of even one sailor to suicide is one too many. We continue to collaborate with the Department of Defense and our sister services to enhance suicide prevention efforts to save lives. Navy suicide prevention is an all-hands, all-the-time evolution. We apply a multifaceted and comprehensive approach to suicide prevention, which involves training and education, intervention, response, and reporting and surveillance. Our training and prevention initiatives run the gamut from an all-hands training to peer-to-peer training to suicide prevention coordinator training to line leader training. And in addition, we have developed and implemented targeted training for various unique populations. Over the past year, we have increasingly leveraged our strategic communications staff to provide innovative and novel ways to encourage the fleet through various social media, and this has been met with great success by increasing interest and active involvement amongst our stakeholders. Our suicide prevention model incorporates a strategic focus which assists us to build resilience, strengthen connections, train various skills throughout the fleet, and reduce barriers to care to help by engaging families, leadership, suicide prevention coordinators, peers, caregivers, and first responders. Over the past year or so, our suicide rate has trended up in the Navy along with in the civilian community. This is similar to the rising trend in the civilian community. 2011, we found that consistent trends continued as in prior years, that most sailors who commit suicide do it when they're in a liberty or leave status. Most are having relationship problems or other common life stressors, and most use a firearm. Actions that we've taken in terms of targeted training include live webinar training, primary care provider training, mental health provider training, as well as some suicide awareness initiatives with certain populations that we find are in contact with high-risk groups, including defense legal counsels, transient personnel unit leaders, and primary care providers. I think I mentioned that. The way ahead, we are integrating our suicide prevention program along with operational stress control, and we plan to have further integration with operational stress control program, continuing to engage our stakeholders and look at other contributors to suicide. We continue to plan to do more targeted training, and this year we plan to do that with the chaplains. And with that, I look forward to our thoughtful discussion today. Thank you.
Good afternoon. The Army Suicide Prevention Program develops and enhances policies designed to minimize suicidal behavior, thereby preserving mission effectiveness through individual readiness for all soldiers, Army civilians, and family members. Our Army leaders are committed to eliminating the negative stigma associated with those seeking help, and our continued emphasis on services, programs, policies, and training that support our Army family remain our focus. We provide resources for suicide intervention skills and prevention. We also track demographics, data on suicide behavior to assist Army leaders in the identification of trends. The Army has had 323 potential suicides during 2012, which includes active duty and not on active duty soldiers, the highest annual total on record. Active duty, including active component, Army National Guard, and U.S. Army Reserve, make up 183 of that 323 total. And 140 of the Army National Guard and Reserve that are not on active duty account for the rest. While most Army suicides continue to be among junior enlisted soldiers, the number of suicides by non-commissioned officers has increased over the last 3 years. Most Army suicides occurred within the age range of 21 to 30, Caucasian male. Most common method of death is gunshot. Most of the active duty soldiers who died by suicide in 2012 never deployed, or they only deployed once. Program initiatives. The Army has a number of programs and tools to assist our soldiers, Army civilians, and family members to combat suicide. I would like to highlight the Company Commander and First Sergeant Pre-Command course and the Applied Suicide Intervention Skills Training, because these areas are our first line of defense to address the threat. The Company Commander and First Sergeant course, which is a 90-minute module embedded in the Installations Company Commander and First Sergeant Pre-Command course. The modules prepare the company commanders and first sergeants to be able to recognize risk factors and warning signs, and provides a number of intervention options depending on the individual soldier's needs. The modules also include vignettes based on real-world case studies and a list of various actions for commanders to take. Applied Suicide Intervention Skills Training is a 2 or 5 day course featuring extensive role-playing and recognition and intervention. The 5-day course is a trainer-trainer course. The 2-day course teaches individuals how to observe and react to risk factors and warning signs for suicide intervention. This training is advanced training for Army gatekeepers. The Army gatekeepers are lawyers, doctors, counselors, chaplains, family advocacy program workers, etc. Anyone that has interacted with soldiers. Fort Bliss has announced that due to training, they have seen a 30% decrease in 2012 from previous years. They attribute this decline to 100% assist 2-day training that is given to their newly arrived personnel by their certified trainers. We have put this information out to the field as a best practice. And in closing, the Army continues to employ a multi-tiered approach to increase awareness regarding suicide prevention and behavioral health services. Subject to your questions.
Thank you. Good morning, or good afternoon, sir, committee members. I'd like to briefly tell you a little bit about the history of our program, where we've been, what we've done since we started, and the changes we've made, and where we're going in the future. The Air Force Suicide Prevention Program was designed in 1996 by a group of professionals across the Air Force. They got together and developed 11 overlapping elements to make up the suicide prevention program, and they designed an evidence-based, leader-led community suicide prevention program. In 1997, we went into full implementation. The 11 elements that we came up with could be broadly categorized into 3 categories. The first one being leadership and community, the second one being education, and the third one being protections for those under investigations. From that point, in early 2003, we began looking at our program evaluating our program to see how it was doing. And we partnered with the University of Rochester in 2003 and 2006 to look at our program. And we found when these 11 elements were fully implemented, our program is most effective. That being said, we also continue to evaluate our program every year, but by the use of an 11 elements checklist. This last year, we had our 11 elements checklist placed into an IG inspection tool for each wing. And what this does is this ensures that each wing has to inspect themselves on how well fully implemented they are on an annual basis and implementing our 11 elements for suicide prevention. This was done through our Community Action Information Board and our integrated delivery systems. These are our entities within the Air Force that we have at the wing level, the major command level, and the air staff level that meet the needs of our Air Force community. The integrated delivery system are those agencies on your base, like your mental health, your family advocacy, your equal opportunity, your chaplains, your legal, your equal opportunity personnel, that meet the needs of the base by implementing outreach and prevention efforts. They report to the Community Action Information Board, which is usually under your wing commander, any problems or difficulties they're having. And then together they work together to take care of the needs of the base. And they form the backbone of the suicide prevention program, making sure it's implemented. In 2010, the report on the DoD report on suicide in the military and the 2010 RAND report on the war within caused us to look more deeply at our program, and we identified places where we could improve. We were able to improve our program by strengthening our 11 elements and enhancing them. And what we have done since then is we have designed an Airman's Guide to Assisting Personnel Distress, which is available for all airmen, that's big A, whether you are an officer, enlisted, or a civilian. We have updated our Air Force Suicide Prevention website. We've distributed resources papers through our CAVES and IDSs. It's the best way to push things down to the airmen in the field. And we are currently revising our clinician's guide for suicide risk assessment, management, and treatment. And we're expecting to release that in the next few months. We took our Air Force instruction on suicide prevention, all the guidance that was in various instructions, and we revised it and rolled it into one document for easy use for the field. As I mentioned earlier, the CAVE directed the end-of-the-year assessment to occur in what's called the Management Internal Control Toolset, which is used by the Inspector General to inspect the basis on how they're maintaining their programs. We also worked on messaging, feeling that messaging is important for from senior leaders down to lowest airmen to have a consistent message of suicide prevention. So we worked with public affairs to develop guidance on how to talk responsibly about suicide prevention. We developed post-suicide response checklists and post-suicide attempt checklists to help take care of the survivors and to prevent future suicides. We also developed memorial guidance for the chaplains to use to help people appropriately grieve suicide. And we developed our training around the Ask, Care, Escort model, or ACE model. In the last year, we conducted live trainings for all of our installation suicide prevention program manager to train them on these changes. We've hosted focus groups with our junior airmen to find out what they're looking for suicide prevention and what resonates with them in terms of a message. And we've also developed a frontline supervisor training, and it's focused at our at-risk career fields, which for the Air Force is intelligence, security forces, and maintenance. We've been looking at them for the last 3 years, and this program has been around for the last 3 years. and it trains the supervisors of these career fields on how to intervene appropriately when needed. It's a one-time training, so we're currently developing a 20-minute refresher training that can be taken online to help keep those skills sharp. And we have recently refreshed our suicide prevention training that goes out to all fields, or all the career fields. We continue to do research with the University of Rochester, and we are partnering with RAND to look at how new technologies may play a role in helping us with our suicide prevention and mental health outreach efforts. And we continue to work, we are also partnering recently with the Air Force Research Lab, looking at personnel well-being, resiliency, and suicide risk. In the future, we remain engaged with the Defense Suicide Prevention Office on their working groups for suicide prevention. And we have expanded our mental health personnel at 300. We have embedded mental health providers in our PA drone units. We have providers in the primary care clinics that provide mental health service on a consultation basis as needed for the primary care doctors. We continue to assess with our PHAs and our post-deployment health reassessments at deployment. And we continue to put out public service messages and campaigns for stigma reduction. And I stand ready for any questions at the end.
The United States Marine Corps conceptualizes suicide and suicide risk as incredibly complex, and that there's an entire array of risk factors and events that increase vulnerability and risk for Marines, and that all these risk factors are incredibly complicated and interactive and interrelated to one another. With that approach, with that conceptualization, we know that we have to design a program, and we have designed a program that is multi-level and multi-dimensional. We intervene at the individual level and prevent suicide at the individual level, at the community Marine Corps level, at the family level, and also at the societal level. And within that, there's many different dimensions, because we know that not one effort or one intervention will solve the problem or prevent suicide. So we have multiple dimensions to our prevention program. We have initiatives that target stigma, stigma reduction. Stigma is the #1 barrier in the Marine Corps that we have to face in trying to get Marines to help and to educate and show Marines that if you ask for help, you are not weak, you are not a weak Marine, and your career will not be jeopardized. And in fact, if you do receive help, you can become even more resilient and a better warfighter. But by far that is our #1 challenge, is tackling stigma around mental health problems and around suicide. Embedded within that stigma is a lot of misinformation and a lot of myths that many Marines have about suicide and mental health problems. And so a lot of our initiatives and training is centered on trying to dispel those myths and to challenge Marines in a discussion format about some of the misconceptions that they may have about mental health problems or suicide, and then give them factual information. We're also involved in a lot of research and evaluation initiatives and projects. We're underway with a psychological autopsy study to see if there are any other risk factors or precipitating events that we're not already aware of. We'll be interviewing, we're partnering with the American Association for Suicidology. They're going to be going out and interviewing families and other members of the Marines family that are surviving, who attempted suicide. We're also involved in a suicide attempts research study I'm the lead investigator on that, and we go around and we interview Marines who've attempted suicide, and our focus is interviewing them and trying to unearth or discover things that we can do to bolster our suicide prevention efforts and to learn directly from them. The interviews last about 3 hours each, and we're gaining some really good information from that. Another part is access to treatment, messaging, and also just having Marine Corps leaders show that it is acceptable to receive mental health treatment and to reinforce that message. And to also educate that mental health treatment does work and what treatment is and what it isn't. There's a lot of myths around that. And then training, we provide suicide prevention training to junior Marines, to officers. And we also have post-vention and reintegration plans and initiatives. We also have a STRATCOM, public affairs strategy, where we have positive messaging and responsible messaging. In particular, when we speak with the media, when we talk about suicide, report on suicide, the do's and don'ts of how you talk about suicide so you don't increase suicide contagion. We also have surveillance. We keep track of suicide, deaths by suicide, and suicide attempts. And we're also involved in assessment and screening of suicide ideation, suicide behaviors. Currently, our Navy psychologist is doing a roadshow, and he is teaching Marine Corps attorneys, Navy chaplains, and all Marine Corps clinicians, family clinicians, and substance abuse clinicians on how to use evidence-based tools to assess for suicide ideation and behaviors, and teaching them safety planning, which is an evidence-based strategy to keep Marines safe that have shown signs of suicide ideation or attempts. The way forward is to, our never leave a Marine behind suicide prevention training program. We will refresh that, and we're going to be trying to front load some of the evidence-based treatment approaches that are out there, cognitive behavioral therapy. Congressman Ryan talked about meditation, and that's one of the techniques used in that. So try to take some of these skills, problem solving, emotion regulation skills, and try to take some of those and put them in prevention and teach Marines some of these coping skills. So that's it in a nutshell for us.
All right, thank you very much for those comments. Congressman had to run and vote, but please, are there any questions? We have the subject matter experts that are managing these programs within their respective services. So this is an opportunity to get some great information. Yes, sir.
Sorry, the question again?
The real number behind 30% decline.
You're referring to Fort Bliss?
Yes.
In 2011, Fort Bliss had 7 suicides. In 2012, they had 6. So that's it. Based on the numbers, that's a 30%.
I had a question. I don't know exactly who can answer it, but it's kind of a general question. From the research that I've done, it shows that the crime it's more of it goes over a pyramid of crime. It's not just suicide that is a problem. That the mental health aspect of some of the issues that a lot of our returning young soldiers deal with. So I know a lot of your research that you guys have talked about has been relating to suicide, but you didn't mention anything about the effects of drugs or exposure and how that affects the mental health aspect when they return home, and especially seeing how we're about to have an increased number of soldiers, young and old, returning home, coming up very soon. What policies have you guys developed or tried to construct that kind of address that in this new environment that everyone's going to be living in?
Well, I think one of the things that the services have done is we have our pre- and post-deployment physical health assessments that are done annually in all of us. And we have them before deployment, before we return home from deployment, once we return home from deployment and about a year to 18 months after that. So we get hit 4 times. You'll find that active duty members screened at that point for any health problems, including mental health, substance abuse problems, depression, PTSD, those type of things, or an assessment. And they can be identified at that time by the primary care doctor and the appropriate referrals at that time.
For Navy, I know that we have also recently added, some more mental health questions to post-deployment health assessments, similar to what Air Force was speaking with. We've also looked at whether there's any relationship with suicide and folks returning from deployment. We have not found that in Navy. However, we've also looked at the relationship of PTSD and suicide in the Navy. We have not found it yet, I think, so far, but we do monitor those things.
Army. Research has demonstrated that suicide is a complex phenomenon, which defies easy solutions. So, and as I stated earlier, the 2012 numbers for Army state that the soldiers that died by suicide in 2012 either never deployed or only deployed once. But we do have policies and programs in place to take care of soldiers when they come back from deployment. They have their pre-deployment briefings and programs that take care of their needs, and this applies to active duty, Army National Guard, and the Army Reserve in their respective states and territories.
Let me caveat to what Sherry just said. So the bigger thing for the Army, and I'm sure the other services are probably experiencing the same thing, is the whole act of the stigma and it being a cultural change for the Army. Stigma has been, if you address the issue, it's looked at as weakness. And we're trying to get totally away from that. And so we've stood up a Ready and Resilient program now. And we actually have senior leaders on the ground across the Army today visiting different installations and conducting, fact-finding missions. One of the things the Army intends on doing, and we've started this as part of that cultural change, is a commander's dashboard. And what that commander's dashboard is intended to do is it will alert commanders on the ground when they receive individuals, particularly those coming back from deployment, of high-risk behavior. And generally in the past, the culture has been, if you've got somebody who's had high-risk behavior, you want to immediately punish them. But the cultural change that we're making is we're going to take this information and use it to help the soldier and their family members, if that be the case, when we identify these problems ahead of time so that we can have services available for them when they arrive to our unit. So that is one of the programs we're about to roll out. Of course, all those kind of things take money, and we think that maybe in the next year and a half, we'll have that program on the ground. But it's just a whole cultural shift, and I think that'll help reduce the whole stigma thing, that soldiers can feel like they will want to come to their leaders to express their concerns and problems, and so that we identify those areas where they need help. And what we're finding in the Army is that suicide, sexual assault, all these different high-risk behaviors seem to be centered around alcohol. And so we're trying to study that now to figure out some programs that we can look across the gamut to affect all those different issues we have.
For the Marine Corps, we've seen that substance abuse, alcohol use, mental health issues, symptoms of depression, anxiety, are risk factors for suicide. Our approach in the Marine Corps, we're not seeing a correlation between deployment and deaths by suicide as well. We're not seeing that. our approach to dealing with deployment and transitions is to use our value, which is knowing your Marine and being connected to your Marine, and always talking, always knowing any differences that you see in your fellow Marine to help with post-employment and also other transitions.
And just to clarify, along with the other services, the Air Force isn't seeing any correlation with deployments and suicide either.
So exposure and the effects of mental health, you haven't seen a lot from that?
You're saying,
Oh, I was just saying that, well, they addressed every other point that I was asking, but I guess the one thing that they're saying they haven't found a correlation with is exposure and deployment and the effects of mental health coming from that.
yeah, and that's the issue, is that when from the last 12 years, what we're finding is that soldiers who deployed for a year or not deployed at all are committing suicide just as much as those who deployed several times. And I mean, we've got soldiers who've done 3, 4, 5 deployments. I knew one personally when I returned from Iraq who'd done 7 deployments, and not 2 or 3 months. It was several months they deployed. So there's really, you can't put your finger on it and say because they've been deployed 5 years they are committing suicide higher. It's across the gamut.
The interesting thing is how much the military populations are not unique in terms of the stressors and things that we see with suicide. They mirror the civilian population, so even though our rates are up somewhat, it's up in the civilian population as well. And the stressors continue to be relationship problems, legal issues, alcohol use, and similar to everyone in the civilian community. So it is kind of interesting. Great question.